Good afternoon, everyone. No introduction, because hopefully you all know who I am. I'm Chris Palmer. So I am going to be talking to you about some work that I've been doing for actually quite a long time, but is increasingly getting attention and traction and funding. And so I'm really hopeful about what this might mean for the entire mental health field. To set the stage, I have no financial disclosures to any of the work that I'm doing other than royalties from a book that I published called Brain Energy. So I want to start the stage with just kind of thinking about mental health today. I think all of you already know we have a mental health epidemic. Prior to the pandemic, it was estimated that about 1 billion people on the planet suffered from a mental or substance use disorder, and that represents 13% of the world's population. And that's the prevalence for just 1 year. Lifetime prevalence rates are much higher. In the United States, most estimates suggest about 50% of people will suffer from a mental or substance use disorder at some point in life. Rates are even higher now due to the pandemic. Mental disorders are one of the leading causes of disease burden and disability worldwide, and some sources will actually say as a whole they are in fact the leading cause of disease burden and disability. And the problem is not always a lack of treatment. For some, it's that our treatments fail to work. And there's this curious thing. Mental disorders, the rates have been rising for decades across a wide range of diagnostic categories. The rates of autism in the last 20 years have quadrupled. The rates of bipolar disorder in the last 20 years have doubled in adults in the United States, and they have gone up exponentially in children and adolescents. The rates of ADHD are up, and in case you didn't know, we have an Adderall crisis, shortage. And rates of depression, plain old bread and butter major depression, what's happening with them? The Gallup poll does an annual survey of current and lifetime prevalence of major depression. Rates were increasing prior to the pandemic, but the pandemic was like pouring gasoline on a fire. And this year in 2023, rates of major depressive disorder have reached an all-time ever recorded high in terms of current prevalence and lifetime prevalence. What are we doing about this? Mental health treatment. We have many treatments. All of you know these well. And there is no denying. I don't want you to come away from this presentation thinking Chris Palmer says treatments don't work. Treatments do work. They save millions of lives every year. And we do much of this life-saving work here at McLean Hospital. But we also need to wrestle with an unfortunate fact that even when people get the best treatments that we have available, they don't always work. Treatment resistance is common. Depending on what studies you look at, anywhere from 20 to 60% of patients with psychiatric disorders have a treatment-resistant form of the disorder. These are associated with increased healthcare burden, up to 10-fold higher costs. Less than 1% of our research funding is on treatment resistance. And this study identifies 3 core problems with treatment resistance. 1, maybe we're not always getting the right diagnosis. 2, maybe we're not providing adequate treatment. And 3, even when people get the right treatment for the right diagnosis, sometimes it just doesn't work. And I'm going to come back to this. But all of this begs the question, why can't we as a mental health field do better? And I would argue it comes down to our inability to answer 2 simple questions. First question is, what exactly causes mental illness? Right now, if you talk to the leading psychiatrists and neuroscientists in the world, they will say, no one knows. It's just too complicated. All we know are risk factors. And we put them into what's called the biopsychosocial model, which says that there are biological, psychological, and social factors that all come together to cause mental illness. These apply to all of the mental disorders. Childhood trauma increases your risk for schizophrenia and bipolar disorder. Anxiety and depression can sometimes be due to a hormone imbalance. So oftentimes people want these simplistic notions that depression is about trauma, or depression, even PTSD is about trauma and only trauma. No, it's actually not only about trauma. It's about much more than just exposure to trauma. How do these fit together? Again, well, yeah, no one knows. The second basic common sense question is, well, what exactly is mental illness? Now, you all know we've got DSM-5, TR, and we have all of these labels that are household names: schizophrenia, bipolar, depression, anorexia, alcoholism or alcohol use disorder. These are household words. Everybody knows these words. And we think that these are valid disease constructs. But in fact, there are three primary problems with our diagnostic labels: heterogeneity, comorbidity, and a lack of validity. So heterogeneity says that if two people have the same diagnostic label, they can be wildly different from each other. You can have a child with autism who lives in a group home, has profound cognitive impairment, bangs his head against the wall to the point of bleeding every day, and we say that that child is suffering from autism. Another person with this diagnostic label can be a billionaire businessman that we see in the news every day. Does anybody in their right mind really think that those two human beings have the same brain condition? The second problem is comorbidity. Comorbidity says that if you have one mental disorder, you're more likely to have another. In nationwide population surveys, if you have one mental disorder, 50% of the people who have one have more than one. If you're actually getting treatment, like here at McLean Hospital, on average, our patients have 3.5 diagnostic labels, which begins to suggest these are not, in fact, distinct disease entities. Why are we mixing and matching diagnostic labels so frequently? And this goes across all of the disorders. People with autism have higher rates of eating disorders and substance use disorders and depression and anxiety and OCD and every label in DSM. Even though people think, well, no, autism, that's a neurodevelopmental, that's a real brain thing. Well, yeah, all of these things are real brain things, and we can mix and match them any way we like. And in fact, Tom Insel and many others have said these are not valid disease constructs and that we need to move on from these diagnostic labels if we as a field are ever going to make progress. And under his leadership, the NIMH proposed the research domain criteria. There are competing models for this, such as the hierarchical taxonomy of psychopathology. These are basically trans-diagnostic models. They get very confusing very fast because there are so many symptoms that we might talk about. So I want to pause right there. The mental health field is a mess. So many labels, so many symptoms, not valid disease constructs. You can mix and match however you like. What on earth are we ever going to do? There are numerous lines of evidence that suggest something quite shocking and, in my mind, filled with hope. There are many lines of evidence that suggest all of the mental disorders appear to share a common pathway or a common pathophysiology. So this was first proposed actually many decades ago, but it was really formally put into the medical literature in 2012 by Leahy and colleagues. And they looked at all the internalizing and externalizing mental disorders and said, gosh, everything seems to lead to all of these disorders, like the genetic research, the neuroimaging research, the risk factors, all of them, you can't you can mix and match anyway. And all of these internalizing and externalizing mental disorders appear to share a general factor with each other. In 2018, Caspi and Moffat expanded on this and looked at every label in DSM-5. At that point, it's probably DSM-4 that they really analyzed, but all of them, all of our labels appear to fall in this general factor, and they called this a P factor. And just this year, Brandt et al. Said, wait, it's more than just mental illness. There are all these physical illnesses that also seem to share this common factor. And they called it a general disease factor, or the D factor. None of this research could tell us what it is. This research just used statistical models, looked at risk factors, and said everything converges, but we don't know what's happening. I want to set the stage for a simpler model. And this really is kind of a way to simplify what RDoC says. What I want to propose is that mental symptoms from any diagnostic label actually fall in a similar category to pain. Under the right circumstances, they can be normal and adaptive. We can have extreme forms. So with pain, pain is normal. We all experience it when we hurt ourselves. We still take pills for it, we still get treatment for it, but it's normal. If you have surgery, you may have prolonged and severe pain, but that's still normal. And then there are these things called pain disorders, in which the pain system is malfunctioning and people can experience the sensation of pain for no good reason. And right now, DSM puts these normal, extreme, and disorder states all into the same category. Because if you are a child being bullied and teased on the playground, that can be normal that you're anxious and have prolonged anxiety symptoms. If it's really extreme, you may have extreme anxiety symptoms and maybe some PTSD symptoms. Those aren't brain disorders. That child isn't suffering from a brain disorder. That child is suffering from social adversity. And the solution is obvious. Stop the social adversity. Help the child cope. But there are, in fact, disorders in which people have anxiety symptoms for no reason, or people have PTSD symptoms for no reason decades later after a trauma. But if we're really going to identify a P factor, and we're really going to talk about disorders, so I'm leaving aside normal and extreme reactions to human experiences and adversity. So I'm going to put those in a different bucket. We still treat those, we need to treat those. But when people have brain disorders, what would we need to account for in order to account for the P factor? I am proposing that we would need to account for, and this is based on decades of neuroimaging and other research, some brain regions appear to be overactive or hyperexcitable, while at the same time other brain regions can be underactive. We also need to account for neurodevelopmental and neurodegenerative disorders, and we also need to account for quote-unquote maintenance problems in brain cells. Things like differences in myelin or the accumulation of abnormal proteins like, tangles and plaques. We would need to account for all of those things with any one theory. And can any theory actually adequately explain all of this? I'm arguing, yes, there is a theory that can explain this. I am arguing that mental disorders are metabolic disorders affecting the brain. All of the risk factors that I've just mentioned and any others that you can think of impact metabolism, that metabolic dysfunction in cells can explain the symptoms of mental illness. This is a way to integrate the biopsychosocial risk factors, and once and for all, we need to stop separating mental illness from physical illness. They are inseparable. Before I proceed with showing you some of the lines of evidence to support what I've just asserted, I want to start with this quote from Albert Einstein. Creating a new theory is not like destroying an old barn and erecting a skyscraper in its place. It is rather like climbing a mountain, gaining new and wider views, discovering unexpected connections between our starting point and its rich environment. But the point from which we started out still exists and can be seen, although it appears smaller and forms a tiny part of our broad view gained by the mastery of the obstacles on our adventurous way up. Why do I share this quote with you? I share this quote because what Einstein was saying is his theory wasn't replacing the theory of gravity or the theory of momentum. His theory was putting them together. What I'm proposing doesn't replace everything that you already know as a mental health clinician or researcher. It is a way to take what you know and put it together in a broader context and understand a bigger picture. And with that, I am going to try to show you just a few, I'm going to give you a snapshot of some of the lines of evidence that support what I am proposing. And it starts with correlations. As all of you know, correlations don't equal causation, but when we see strong bidirectional correlations between two disease entities, we need to at least consider the possibility of a common pathway. And there are strong bidirectional correlations between mental illnesses, all of them, and all of the things that you see on the right-hand side of the screen: obesity, diabetes, cardiovascular disease, and Alzheimer's disease. And as most of you know, obesity, diabetes, and cardiovascular disease are metabolic disorders. What connects those three things? Metabolism. They are metabolic disorders. And what really I'm proposing is that mental illness needs to be included in that mix now. If you have a chronic serious mental disorder, you have 2 to 3 times the risk of obesity and diabetes. You have a higher risk of cardiovascular disease and premature mortality from it. If you have chronic depression, you have 2 to 3 times the risk of developing Alzheimer's disease. If you have schizophrenia and live to the relatively young age of 66, you have a 20-fold increased risk of also having dementia on top of your schizophrenia. 20-fold, 2,000%. What about the other way around? People with obesity, 50 to 350% increased risk for a wide range of mental disorders throughout the lifespan. Diabetes, 2 to 3 times the rate of mental disorders. Cardiovascular disease, 3 to 5 times the rates of mental disorders. Alzheimer's disease. Once you get diagnosed with Alzheimer's, essentially 100% of people will have symptoms of mental illness. Anxiety, depression, agitation, insomnia. 40 to 50% will have hallucinations and delusions. Those are the hallmark symptoms of what we call schizophrenia. So I want you to think about it. If you have schizophrenia, you have a 20-fold increased risk of developing Alzheimer's. And if you have Alzheimer's, you essentially have a 50-fold increased risk of developing the hallmark symptoms of schizophrenia. We can't talk about the root cause of mental illness without talking about the root causes of these other disorders. And metabolic disorders affect every system in the body, affect all sorts of tissues. This population study of over 6 million people, if you are first diagnosed with a mental disorder, you have a dramatically increased risk of developing a wide variety of physical disorders. All of the metabolic disorders, but also some autoimmune ones and other ones that, at the end of the day, all relate to metabolism. And in fact, none of this should come as a surprise to any of you. We have long known that people with mental disorders die early deaths. People with chronic serious mental illness die anywhere from 7 to 30 years early, depending on what study you look at and what population you look at. But actually, a very large population study of over 7 million people published in The Lancet a few years ago suggests something more shocking and tragic for the community we serve. All of the mental disorders, each and every one of them, are associated with a reduction in lifespan. On average, men are losing 10 years of life and women are losing 7 years of life. What are these people dying of? Well, everybody always thinks suicide. Oh, those mentally ill people are killing themselves. Well, yes, They do kill themselves. And yes, that does influence the statistics. But the leading cause of death in our patients and the people that we serve and the people that come to us for help are heart attacks and strokes and premature dementia and obesity and diabetes. Why? Why are our patients dying early deaths? This has not gone unnoticed. The World Health Organization has put together a task force, published a report in 2016. They basically said, we think it's related to factors related to the individual's behavior. That means the mentally ill overeat and underexercise. Or maybe they're disorders. Maybe it's medication side effects. Problems at the health system level, people with mental illness don't go to their doctors and follow orders like they should. Wider societal issues, people with mental illness are more likely to be unemployed and poor. And we know from large population studies, unemployed poor people die early deaths. So maybe that's why our patients are dying early. I believe we are missing the elephant in the room. Many of these things are about blaming the victims. Overeating and underexercising can be a sign of metabolic impairment in your brain or body. In fact, this is nothing new. Metabolic problems have been identified in the brains and bodies of people with mental illness for over a century. We have a century of clinical and epidemiological study. Basic science research dates to the 1930s. It includes pretty much a wide range of diagnostic categories. There are a lot of diagnoses in DSM-5, and some of them don't get a lot of funding, so I can't say that we have evidence for every diagnostic label, but we have evidence for depression, anxiety, PTSD, schizophrenia, bipolar, anorexia, and alcohol use disorder, and Alzheimer's, which gives us a wide range, and autism. I didn't include those. What do I mean when I say metabolic problem? I mean, when we look at neuroimaging studies or cell biology studies, we see differences in the levels of lactate, glucose metabolism, the ATP to ADP ratio, reactive oxygen species, redox markers, levels of NAD to NADH, inflammation, cortisol, brain insulin, mitochondrial function. I'm not going to get nerdier than that, because I know you all don't want to hear that. Now, one of the things that people, even mental health professionals, really struggle with is they're like, Chris Palmer, no, my patients really do overeat and underexercise. And it is the pills. The pills are doing it. I don't think you're right. This research suggests something different. Large longitudinal study of over 5,000 children followed from the ages of 1 to 24. Children with the highest levels of insulin resistance beginning at age 9 were 5 times more likely to have a psychosis at risk mental state and 3 times more likely to already be diagnosed with schizophrenia or bipolar disorder. The children who gained the most weight around the time of puberty were 4 times more likely to develop depression. Now, a lot of times people think, well, that's fat shaming. Yeah, fat shaming is part of that. But obesity represents a metabolic problem that is occurring in the brains and bodies of people. And it is influencing other brain functions than just feeding behavior. And so instead, I want you to develop a more complex model. Some people think metabolic, so are you saying, based on that study, so are you saying all kids have a metabolic problem that we can measure, like insulin first, and then they get psychotic? No. Some people, the first sign of a metabolic problem is a brain symptom like psychosis or depression or anxiety. And instead, I want you to think in a complex feedback loop. So we have these mental things. A lot of people think mental illness that's a neurotransmitter problem, chemical imbalance. Or no, it's stress and adverse childhood events and trauma and loneliness or addiction. That's what mental illness is. They think that's the core of mental illness. Neurotransmitters or psychosocial stressors. And then metabolic problems like obesity and diabetes, well, those are really simple problems too, Chris Palmer. That's a problem of diet and exercise. If people just followed the right diet and the right exercise plan, they would be fine. And I'm here to tell you neither category is quite so simple. We've long known that there is a both category. Genetics and epigenetics play roles, hormones, inflammation, sleep, the gut microbiome. But what I'm here to say is that all of these things are interconnected. Childhood trauma can cause a heart attack. Childhood trauma can cause obesity or contribute to the development of obesity. Childhood trauma can contribute to the development of insulin resistance that turns into diabetes. We've long known this. We call that social determinants of health. Without understanding how it all fits together, we aren't doing anything for the people we serve. They're still all dying early deaths. And the shocking thing is we almost never talk about diet and exercise as a treatment for serious mental illness. So I'm saying metabolism, metabolic, what does that mean? So a lot of people think of metabolism as burning calories. It's that simple thing. It's how many calories you burn, and that's really all it is. Well, actually, no, that's not all it is. It is, a simple definition might be converting food into energy or building blocks used to maintain or grow cells, and the management of waste products. In fact, metabolism is fundamental to the definition of living organisms. When metabolism stops, life stops. It's called lack of oxygen or lack of food, starvation, suffocation. Those things, why do they result in death? They are stopping metabolism. So in a way, metabolism is ridiculously complex. Hundreds, if not thousands, of pathways and enzymes and molecules and all sorts of things playing a role. So in this sense, if I'm really saying mental disorders are somehow or another related to metabolism, some people are like, well, duh. Of course. How could it not be if you're taking such a broad definition of metabolism? But if we ask another common sense question, well, what exactly controls metabolism? The answer is, in fact, lots of things, and they are biopsychosocial things that all influence metabolism. But if you really do a deep dive into the science of metabolism, time and again, you will be led to these tiny things in our cells called mitochondria. Now, mitochondria, most people know them as the powerhouse of the cell, but I'm here to tell you, cutting-edge research over the last 20 years completely shatters that simplistic notion and definition of mitochondria. I would argue they are, in fact, the central regulators of metabolism in the human body. There are hundreds or thousands of them in each cell. They are highly dynamic. They move around cells. They fuse with each other. They bud off from each other. And if you ask even researchers who do mitochondrial research, what exactly are mitochondria? Just like asking blind researchers to describe an elephant, they might give you different answers depending on what tools or aspects of mitochondrial biology they are studying. And if you do a deep dive into the science of mitochondria, it gets overwhelmingly complex fast. Mitochondria have different phenotypes, functions, activities, behaviors. It gets overwhelming fast. But we have enough evidence, without diving in or even knowing all of that overwhelming complexity, for me to be able to say, if there is any unifying link to help us understand a P factor or a D factor, it almost certainly must be mitochondria. Mitochondria play a direct role in the production and regulation of neurotransmitters like serotonin, dopamine, GABA, glutamate. They play a role in epigenetic expression. Many risk genes for mental illness directly influence mitochondrial function. They have a role in turning inflammation both on and off, and yet chronic infections directly influence mitochondrial function. The gut microbiome, diet, and exercise play a role in their function, but their function in certain brain cells plays a role in how much we eat or don't eat. Their function in muscle cells plays a role in whether we have energy to exercise or not exercise. Adverse childhood events, stress, and trauma directly impact their function. Drugs and alcohol do, sleep. Mitochondria play a direct role in the production of all steroid hormones. This includes cortisol, estrogen, testosterone, and progesterone. All of you probably know those play a role in mental illness. Those hormones then in turn influence mitochondrial function in other cells. The good news is that I'm not just alone. I'm not a lone quack. There are other researchers. This particular study put it together in a different graphic, actually citing some of my work. Mitochondria seem to be the unifying link of trauma, stress, genetics, epigenetics, diet, lifestyle, all of this. And we can actually trace the pathways to understand brain dysfunction. And for those of you who are like, no, it's trauma, and Chris, don't talk to me about biology. This is about trauma. Well, stress and trauma directly change your metabolism and mitochondrial function. And if they occur over a prolonged period, that can lead to dysfunction in mitochondria and metabolism, which leads to dysfunction of cells, which leads to illnesses and disorders. And if you do a deep dive into the science of, well, if mitochondria in a cell were in fact dysfunctional, what could be a consequence? What are the theoretical consequences? And in fact, we can at least address what I have set out to address. We can begin to understand why some brain regions might be overactive or hyperexcitable, while at the same time other brain regions might be underactive. If these things are occurring during neurodevelopment, it can result in neurodevelopmental disorders. If they occur over a prolonged and extreme way, it can result in neurodegeneration, and it can result in maintenance problems in cells. I want to make clear, in many ways this is nothing new. In the 1800s, researchers noticed diabetes is a disease that shows itself in families in which insanity prevails. Before we had antipsychotics that caused obesity and diabetes, they already knew diabetes and insanity go together for some reason. Within 10 years of discovering the insulin molecule, we were injecting it into the mentally ill. And it was actually one of the most widely used treatments for serious psychotic and mood disorders in the Western world. In the 1930s, abnormalities in lactate and glucose metabolism were first identified in the bodies of people with bipolar disorder and schizophrenia. The mitochondrial theory of autism was first proposed in 1985. You know all those functional imaging studies that we're doing, PET scans, SPECT scans, functional MRI, all those things? Well, guess what they're measuring? They're measuring brain metabolism. That's what we're measuring. So when we are looking for differences in those brain scans, we're looking for differences in brain metabolism. The mitochondrial theory of bipolar disorder was first proposed in 2000, and within a few years, 2004, right here at McLean Hospital, Christine Conradi and Bruce Cohen and colleagues added great support to the mitochondrial theory of bipolar disorder. And for the last 20 years, he, Dost Unger, and others right here at McLean Hospital have been studying the mitochondrial basis of bipolar disorder and schizophrenia. So that's a theory. The reality is a theory opens up entirely new avenues for research and entirely new ways to think about how can we do better for the patients we serve. But much more important, I have always been a clinician, and I remain a clinician, and I am particularly interested in, well, what can we do for people today based on this? First and foremost, I want to say that we need to adopt an integrated human healthcare model. Right now, we prescribe treatments that cause obesity, diabetes, cardiovascular disease, and we turn a blind eye to the fact that our patients are dying 30 years early deaths. That's not okay. I want to be the first to say that is not acceptable. We need to do better. There are many treatment options. These treatment options include all of the usual suspects in the mental health field. A new theory doesn't replace what we know. So yes, we can continue to deliver care that we know works for people. But when care isn't working, we might want to start seriously considering diet and nutrition, or vitamins and supplements, or metabolic medications, or hormone imbalances, and get much more sophisticated in how we address those things. I want to come back to that article. So this is a mainstream research article. Treatment resistance is common. We need a correct diagnosis, adequate treatment, and we need to address non-response to treatment. What I'm proposing is that with correct diagnosis, we need to think beyond mental symptoms, and we need to think beyond DSM. We need to start with a comprehensive biopsychosocial assessment of risk factors and contributing causes. We need to measure and think about metabolic biomarkers such as glucose, lipids, weight, blood pressure, visceral fat. We need to be thinking more clearly and concretely about hormone imbalances, vitamin and nutrient deficiencies. We rarely screen for these. We need to start thinking about screening for these things in our treatment-resistant patients who aren't doing well. Think about sleep and circadian rhythms, substance use, medications. The reality is probably one of the most bold and disruptive aspects of what I'm proposing is that some of the medications that we are prescribing result in short-term reduction of symptoms but potentially keep people ill for life. And we need to really take that seriously and think about what are we doing and can we do better? Adequate treatment, this is stuff you already know. Medications, let's not go crazy with medications. Let's please not prescribe 6 different medications over the course of 1 month. Medications don't work that fast. We know that. We can make people delirious by reckless psychopharmacology. And there's more to mental health treatment than pills, psychotherapy, housing, employment, relationships. You're McLean Hospital. You already know this. I want us to rethink our current treatments. A new theory doesn't replace what we know, but it can totally blow our minds in terms of, oh my God, is that what we've been doing all along? I want to give you 2 examples. Serotonin. We all know serotonin plays a role in mental illness. We prescribe lots of medications that impact serotonin. Does serotonin, Chris Palmer, have anything to do with metabolism or mitochondria? If you don't know this, it has everything to do with metabolism and mitochondria. 90 to 95% of the serotonin in the human body is produced in our digestive tract. Serotonin plays a profound role in metabolism and mitochondrial function. It is actually absorbed in mitochondria and turned into melatonin, which serves an antioxidant function in, it's hard to say all cells ever measured do this in the human body. Seemingly, every organ and tissue in the human body uses serotonin to serve as an antioxidant within mitochondria. The gut and brain have connections that play a role in mental and metabolic health. And when we prescribe Prozac, many of us think we're correcting a serotonin imbalance in the brain, but those serotonin imbalances in the brain have never been identified, despite decades of looking. And in fact, it may be that the SSRIs, when they work, are actually affecting the gut or levels of serotonin throughout the body and doing other things that are influencing mitochondria and metabolism in ways that we haven't even considered. Lithium. Lithium's a mood stabilizer. It really works, at least for some people. What does that have to do with metabolism or mitochondria? This study published last year looked at all of the known mechanisms of lithium, looked at all of the molecules that it is known to affect, and lo and behold, they all converge on insulin signaling pathways, which converge on mitochondria. Now I want to ask the question, can a metabolic treatment, so that just helps us understand maybe our usual treatments and what we're doing, but can we do anything else? Are there new treatments, novel treatments that could play a role? And I want to turn our attention at least to metabolic medications. So statins are for cholesterol, calcium channel blockers are for high blood pressure, and metformin or biguanides are for diabetes. These are metabolic medications for metabolic syndrome. Do they play a role in mental illness? This large population study of people with psychotic disorders looked at, it's a retrospective study, so this is not a randomized controlled trial, but it's a retrospective study looking at in patients who happened to be taking one of these medications, did it do anything? Did it keep them out of the hospital for heart attacks and strokes, number one? And number two, did it keep them out of the hospital for psychiatric symptoms? Shockingly, it worked pretty well for the mental symptoms. It kept them out of hospitals across the board for psychiatric hospitalizations. It reduced self-harm. It wasn't so great at keeping people out for non-psychiatric hospitalizations, the statins and the calcium channel blockers. Metformin did a better job across the board. But look at the reduction in self-harm with a calcium channel blocker, a blood pressure medicine. SGLT2 inhibitors. These are medications used for diabetes. This review in the Harvard Review of Psychiatry, there are lots of diabetes meds, the weight loss medicines, the GLP-1 agonists like Ozempic, Wegovy, those things. Researchers are all over those right now. Lots of signals that diabetes medicines may play a profound role in the treatment of mental illnesses, substance use disorders, all sorts of things that we treat. There are phase 3 trials of the weight loss and diabetes drug for Alzheimer's disease right now. But I want to talk about diet. So if we're doing a dietary intervention, first and foremost, there is no one-size-fits-all recommendation. I'm going to talk about the ketogenic diet soon. It gets people excited. I do not want any of you to come away from this lecture thinking the ketogenic diet is the miracle cure for everybody and I'm putting everybody on the keto diet. That is not what this is about. Dietary interventions have broad goals. Some people need to lose weight. People who are overweight or obese might need to lose weight. Some people are normal weight. They need to maintain their weight. Other people need to gain weight. People with severe eating disorders who are grossly underweight. People with severe depression and cancer who are emaciated. They have a metabolic problem not because of obesity. They have a metabolic problem because of the other end of the spectrum. They have a metabolic problem due to vitamin and nutrient deficiencies or calorie deficiencies. Both ends of the spectrum are a metabolic problem. If you have a hard time understanding that, blood pressure needs to be right. It can be too high, and that's a problem. It can be too low, and that's a problem. Blood glucose needs to be just right. It can be too high, and that's a problem. It can be too low, and that's a problem. Weight, same thing. So this is not about Chris Palmer saying everybody with a mental illness is obese, and all obese people have a mental illness. No, that's not what I'm saying. I'm saying it's a lot more complicated than that. Dietary interventions may address nutritional deficiencies. We might remove allergens, toxins, chemicals, healthy diets, gut microbiome, and we can change metabolism. And I'll just walk through a couple of examples. So we have one small pilot trial, 67 patients with major depressive disorder, who were randomized to 12 weeks of either a group that taught them how to do the Mediterranean diet or a social support group. The patients who got the Mediterranean diet group had a 32% remission rate versus an 8% remission rate in the social support group. On one hand, that's really impressive. It's a fourfold increase rate of remission. On the other hand, 68% were still depressed with the Mediterranean diet. So we need to be more sophisticated than just tell everybody to do a Mediterranean diet and think that's going to solve the problem. And now I want to talk about the ketogenic diet. So a lot of people know the keto diet. They've heard that it is a dangerous fad diet. Do not do that diet. It's going to give you a heart attack. It's going to kill you. Don't eat that food. Don't listen to those quacks promoting it. The reality is that the ketogenic diet was developed over 100 years ago now by a physician for one and only one purpose: to stop seizures. It is a diet that is high in fat, low in carbohydrate, moderate in protein. It mimics the fasting state. It is now, in fact, and if you believe in randomized controlled trials published in the New England Journal of Medicine and other prestigious journals, you must believe that it is an evidence-based, effective, safe treatment for weight loss, type 2 diabetes, and epilepsy. That is what the medical literature tells us. Over 100 randomized controlled trials. It is irrefutable. Patients in those trials didn't drop dead. They didn't. Epilepsy, why is this important to me as a psychiatrist? We use epilepsy treatments all the time in psychiatry, every day. You all probably have at least one patient, if not dozens of patients, who are on epilepsy treatments. Lamictal, Depakote, Tegretol, all the benzos, gabapentin or Neurontin. Many of these medications were first developed for one and only one purpose: to stop seizures. How does a diet stop seizures? The reality is we have a tremendous amount of neuroscience literature on this. Researchers, biotech companies, others have been studying this diet relentlessly for decades now, trying to understand how it stops seizures even when medications fail to. Mainly because they're looking for new targets. They're looking for new drugs to develop, and so they want to understand. The diet does many things. It changes neurotransmitters, decreases inflammation. I want to point you to this center. It changes mitochondrial function. It results in two things. One called mitophagy, which is getting rid of old and defective mitochondria and replacing them with new ones. And it also results in the production of new mitochondria in cells, so that when people have done this diet for months or years, it doesn't happen overnight, unfortunately, and it doesn't happen in 1 week. Months or years, their cells have more healthy mitochondria, and that may, in fact, have healing potential for some of the people that we treat. Is there any evidence? Right now, the research is in the early days, so we have pilot trials, mostly. We've got larger randomized controlled trials of epilepsy. I'm not going to share that with you. That is unequivocal. We have 2 Cochrane reviews on epilepsy documenting its efficacy. We have this is probably one of the best published studies on Alzheimer's disease so far, a randomized crossover trial of 26 patients. All of them were assigned to either a low-fat diet or the ketogenic diet, separated by a 10-week washout. When the patients were on the ketogenic diet, they had improvement in activities of daily living, quality of life, and they actually also had improvement in cognition, but the cognition score did not reach statistical significance. The others did reach statistical significance. There are larger trials for Alzheimer's disease underway now. Alcoholism. What the hell does that have to do with the diet? Well, we've long known that alcohol use disorder is associated with brain glucose hypometabolism, a metabolic problem in the brains of people with substance use. Animal models have demonstrated reduced alcohol intake while rats are on a ketogenic diet. This pilot trial led by Nora Volkow, the director of the National Institute of Drug Abuse, that was done at NIAAA, recruited patients with alcohol use disorder, admitted them to a detox unit, and they all got the standard detox. Half of them were assigned to a ketogenic diet, half of them got the standard American diet. The patients who got the ketogenic diet had fewer alcohol withdrawal symptoms, they got fewer benzodiazepines, they had fewer cravings for alcohol, And when they did brain scans, they noticed improved brain metabolism and reduced brain inflammation. Schizophrenia, bipolar disorder, and depression. I have published several case reports, small pilot trials now. This one case series from France looked at 28 patients who had treatment-resistant bipolar disorder, depression, schizophrenia, put them on a ketogenic diet. Of those patients who completed the diet, 100% had at least some improvement. 43% achieved clinical remission. 96% of them lost some weight. What a nice side effect. 64% of them were discharged on less medicine. So it wasn't the hospital was increasing meds. This is probably the most reputable study published to date, just out about a month ago. They recruited patients with euthymic bipolar disorder, so not currently in a mood state. They put them on 6 to 8 weeks of a ketogenic diet. 27 patients were recruited, 20 completed the study. 91% of all of the readings indicated ketosis, a high level of adherence. So one of the biggest arguments I hear is nobody can do a keto diet. Well, these patients with bipolar disorder could. 91% ketones, that's pretty good. They happened to lose some weight, about 8 pounds on average. Oh, their blood pressure went down. Isn't that nice? Oh, they did MRS. Oh, they had changes in brain metabolism and the glutamate-glutamine kind of ratios in the ACC and PCC. Of the patients who were in ketosis, they noticed a trend. As ketones went up, mood improvement went up, impulsivity went down. They got improvement in anxiety. And what is that one? I can't read it. Energy, I'm sorry. My eyesight, bad. I need my reading glasses based on the monitor I'm looking at. So energy went up. Thoughts did not change. But again, these were euthymic bipolar patients, so they were not currently having an episode, so they, in theory, should not have had significant thought disorders. And of the patients who participated in the trial, 1/3 of them said, I'm going to stay on this. And some of the quotes were pretty impressive in terms of this has changed my life. What if you have a patient who might be a candidate for the ketogenic diet? First and foremost, I want to just say to you, a medical audience, this is a medical intervention. Please do not tell your patients, go out and look on the internet and look for keto and try it out. I saw something keto in Costco the other day. Go get that and just try eating that and see if that changes your brain. See if that treats your schizophrenia. We wouldn't do that for somebody with seizures. We shouldn't do that for the patients we serve. They deserve competent, sophisticated medical interventions. The ketogenic diet is a sophisticated medical intervention. There are some risks with it. During the adaptation period, the first month, many patients can get hypomanic and manic. And I am one of the few people noticing that and talking about it. Psychiatric, and again, this is not a standalone treatment. Patients may need to have medications adjusted. They may need psychotherapy. They may need other aspects of treatment. The great news, if you happen to have any patients with bipolar disorder or schizoaffective disorder, Dr. Virginie Anne Chouinard, Dost Unger, and others are going to be starting a trial of the ketogenic diet for those disorders right here at McLean Hospital. So they will begin recruiting probably after the holidays. So if you do have any patients that you think might be candidates, you could think about sending them their way. And it is an honor to announce that I have received a $3 million gift to start a metabolic and mental health program here at McLean Hospital. So I am going to be hiring for this, both clinicians and researchers. So if anybody listening is really fascinated and interested in this work and wants to think about applying to this program, I will be hopefully taking applications soon enough, as soon as I work with HR to get all of those processes finalized. And we will be developing a consultation service to serve McLean Hospital patients. It probably won't be operational for at least 4 months, is my guess. It'll depend on how quickly I can hire and train staff. But we will actually be offering a wide range of metabolic treatment interventions. The ketogenic diet will be one of many, but there will be lots of others: diabetes meds, looking at tweaking medications, looking at adding exercise or other nutrition interventions. So at some point over the next year, if you have patients that you think might be interested in trying a different approach, in particular patients with treatment-resistant mental disorders, we have lots of those here. If they want to try something a little different to see if they might get something that changes their life, we will be available. The great news is that this is spreading fast. Research trials are already taking place here at McLean and Harvard, at Oxford, Hopkins, Stanford, all over the world. And with that, I want to thank you. I'm happy to take questions if people have them. Any questions? If you don't, for the live stream so people can hear.
Okay, to circle back to the beginning where you started by illuminating in the last 20 years, the incidence of all these diagnoses that you spoke of, I'm guessing that the metabolic changes aren't happening spontaneously in developing fetuses over the last 20 years. It all just blossomed somewhere. So what, in your mind, are the possible exposures or whatever that's taking place in pregnant women so that these metabolisms are, these fetuses are developing metabolic disorders that can manifest the way they are in this increased like this?
I mean, that is the trillion-dollar question today that is highly debatable and contentious. And before I give you a possible answer or possible answers, I just want to say our entire society is based on massive industries that depend on these systems remaining in place. So anybody who suggests that factor X might be playing a role in the obesity and diabetes and mental health epidemics in the world, anybody who suggests that is quickly labeled a quack and discredited. I think it's pretty clear that there's something in our food that is probably contributing, and that gets into all of the processed foods and the chemicals and additives and artificial sweeteners and other things that are in our food supply. There was an animal model just published several months ago looking at aspartame, that aspartame causes anxiety symptoms in mice, and that can be transmitted for 2 generations in mice. So if that data transfers to humans, it suggests that if your grandmother drank a lot of Diet Coke, you might have an anxiety disorder today because of her consumption of Diet Coke. There are environmental toxins, air pollution, microplastics, the PFAS and other chemicals. And we know from many studies, both animal studies and in kind of in vitro cell studies, that those chemicals directly influence mitochondrial function and result in metabolic abnormalities in the way those cells function. We know that those chemicals can induce all sorts of things in mice. Even the United States Environmental Protection Agency has right on its website that those chemicals, in fact, are hormone disruptors, that they are changing human hormones such as cortisol, estrogen, testosterone, which are, the synthesis of those begins in mitochondria. So again, it all fits together. But even though the EPA acknowledges that, well, what are we going to do? What are we going to do about it? Come on. Like, are we really going to disrupt our whole society? Like, we can't possibly get rid of all of those chemicals. Plastic is everywhere, and plastic is convenient, and I think that's the challenge. In my mind, I think the most logical next step is for us as a medical field to acknowledge the big picture and do more research to rule in this theory, hypothesis, rule it out, refine it, augment it, whatever. Like, let's get to the truth. But if what I'm suggesting is true, and I'm pretty persuaded that it is, there's an overwhelming amount of evidence that it is, it's pretty easy to identify chemicals that disrupt mitochondrial function. That's not rocket science. The challenge is, oh my gosh, there's so many of them. What on earth are we going to do about that? So for now, what I really usually recommend, changing the food supply seems to result in health improvement in the overwhelming majority of people. And so what I typically recommend is eat real whole foods. Stay away from processed foods, stay away from things with chemicals and additives, eat real whole food. Try to make that the mainstay of your diet. Obviously getting sleep and exercise and lots of other things, avoiding drugs and alcohol and substances and medications that harm metabolism are important. But a lot of people get better by just switching their diet, and it makes sense. The thing that we're putting into our bodies on a daily basis primarily is food and water. And so it makes sense that that's probably the primary toxic source.
And thank you. And also, I'm not a doctor, so I know very little about this, but I was wondering if this can also be related to like psychosomatic symptoms or functional neurological disorders of like, that we don't really see it like as a physical thing, but it can also be like a metabolic inflammation, microbiome related stuff. I don't know if you know anything about that.
For which disorders?
For psychosomatic symptoms or like functional neurological disorders.
Yes. So functional neurological disorders get super controversial fast, as you probably know. And there's already a tremendous amount of evidence that mitochondrial dysfunction is playing a role in long COVID, for instance. And some people put long COVID into a functional neurological category because we don't have clear biomarker tests to say this person has long COVID and this one doesn't. And yet a lot of the cutting edge research on long COVID and what it's doing is converging on mitochondria. It gets very complicated fast though, because anytime we have a virus or bacteria or parasite residing in our bodies and reproducing in our bodies, they are stealing metabolic resources to reproduce themselves. And that leaves us vulnerable. And so any chronic infection might contribute to the development of a wide range of these disorders. There was research that just came out the other day that people who've had cats as children have double the risk of developing schizophrenia, and that leads to toxoplasmosis, which is a parasite that's present in 40 million Americans. Most of us have toxoplasmosis, or a lot of us, I shouldn't say most, many of us have toxoplasmosis in our cells. We don't clear that out. It's usually not a problem unless somebody becomes immunocompromised. And immunocompromise happens when people gain weight, develop a metabolic problem, get stressed, have sleep deprivation. They might become immunocompromised slightly, very slightly. That might allow toxoplasmosis to play a more meaningful role in their brain. And then they come in with psychosis. And we say, well, no wonder you're psychotic. You had sleep deprivation. You were really stressed. Yeah, we see that all the time. But we don't bother looking for the toxoplasmosis or think about treating it. So I do think that it almost certainly plays a role in what we call functional neurological disorders. Can there be psychological reasons that people have certain symptoms? Of course there can, secondary gain or other things, but more often than not, having worked with a lot of those patients, I don't think they're like making it up. I don't think they're even unconsciously making it up. I think they're really suffering from a true biological problem that almost certainly relates to metabolism or mitochondria. And so if we can develop more sophisticated assessment and treatment strategies, I think we might be able to help those people better. Any more?
Thank you. I was actually wondering, because you go from observation to treatment without basically addressing how would you study the metabolism, but also the mitochondria in the brain with and without disorders, but also affecting only the metabolism in the brain without affecting the metabolism in the rest of the body. How would you study that, basically?
So all of the neuroimaging studies that we've been doing are measuring metabolism in brain cells. That is what all of those studies are doing. So that's one easy way that we have decades of experience doing. And again, so that very first theory of the metabolic theory of bipolar disorder was based on neuroimaging studies. They basically looked at all the neuroimaging data. They found higher levels of antioxidant stress, lower levels of glucose metabolism, other things. And they asked the simple question, like reduce glutathione levels, which are central to antioxidant function within mitochondria. All of these complicated things. But they looked at all of them and they said, where do these things converge? If all of these things are playing a role, is there anywhere in the cell or the brain or whatever that they converge? And they all converge at the level of mitochondria. But the real answer, a common question that I get is, so what's a test that I can do to measure my mitochondrial function? There isn't one. That's not the way mitochondria work. And in order for people to really, in case you don't get it, I just want to help you get it. We have 3 disorders that nobody really argues are metabolic disorders. There's this thing called obesity. That's a real thing. It is a real problem. We can see it, we can measure it. There's this thing called heart attacks. That's a real thing. That's a real problem. We can measure it. We can see it. And there's this thing called diabetes. We can measure it. How are those 3 things interconnected? We say they are metabolic in nature. There is no way, it is impossible to connect those 3 disorders without going to mitochondria. You cannot do it. They are mitochondrial problems. They are disruptions in mitochondria. I just want to stay with that. So does that mean everybody who's obese has a heart attack every day? Does that mean that everybody who's obese immediately develops type 2 diabetes as well? No. Does that mean that everybody that got type 2 diabetes has obesity? No. Does it mean that everybody with type 2 diabetes has a heart attack? No. Does it mean that all heart attack people are obese? No. You can be thin and have a heart attack. How can you be thin and have a heart attack? Lots of ways, but let me give you a clear one that everybody knows. Smoking cigarettes. Smoking cigarettes causes mitochondrial dysfunction. No ambiguity about it. Smoking cigarettes is causing a metabolic problem, even though on average smokers are thinner than non-smokers. So smoking increases risk for a heart attack. Smoking, unbeknownst to a lot of people, doubles your risk for developing type 2 diabetes. Even though most people think of type 2 diabetes as a disorder of obesity, it's not. It's a disorder of mitochondria and metabolism. And you can be a thin smoker and become diabetic because you're poisoning your mitochondria. So I just want to stop with those 3 things. So if we measure biomarkers in those three people, if I measure biomarkers of mitochondrial function in heart cells, some people may have profound mitochondrial dysfunction in their heart because they have angina, or they have clogged arteries, or they have what's about to become a heart attack, or they just had a heart attack last year. They're going to have profound mitochondrial dysfunction in their heart. But somebody with obesity may have a seemingly fine heart with normal mitochondria. So that's one of the challenges, is that mitochondria can be dysfunctional in some cells and perfectly functional and healthy in other cells. So that's where some people are like, then Chris, you're not telling us anything useful if it's that complicated. But it is useful. Because the same strategies, so if I have somebody with obesity, diabetes, and who's at risk for heart disease, I can recommend an all-in-one prevention strategy for that person. I'm going to talk with them about diet, nutrition. I'm going to talk with them about good sleep, an exercise plan, and stay away from drugs and alcohol. And that's going to be a threefer. It's going to treat all three of those metabolic problems. What I'm here to say is that we'll probably also treat their mental health problems at the same time. And so sometimes generic lifestyle strategies or a supplement or something else that improves mitochondrial function can have broad effects. And it doesn't necessarily matter where exactly in the body the symptoms are coming from, or where exactly in the body the mitochondrial dysfunction is occurring. The where will tell us, the symptoms will tell us where in the body it's likely occurring. And so it is different. But again, if somebody's got obesity and another has diabetes and another is at risk of heart disease for another reason, I can recommend a really comprehensive package, basic common sense lifestyle treatment plan that will probably address whatever they've got. So I could include people with obesity without the other two. I could include people with diabetes without the other two. I could include people with all three, and the exact same treatment plan is going to address most of them. Might some of them have rare genetic predispositions that make them more likely to have clotting or other things? Yes, of course. But those are rare. And the people who want to hold to the genetic theory doesn't hold water, because we see skyrocketing rates of all of these disorders in society. It's not in our genes. It's in our environment. It's something in our environment.
If it's more in your environment and less in your genes, how can you use what you've been talking about today to take into consideration kind of like the transgenerational inheritance of those mitochondria from your mother? Like you were speaking about, you know, you could have something. I'm from an aging background and from maternal age effects, so the cumulative effect of, say, your mother having, or the maternal line in your family being older mothers, and then having you, and that cumulative effect of, you know, going down the line, just having old, and life history changing, how then are you going to factor that into the consideration of, like, the environment? Like, how would you play with those maternal effects that are just inherent in getting your mitochondria, since you get them from your mom?
Well, and it, I want to even add to that, because we inherit all sorts of epigenetic factors that influence mitochondrial function and metabolism from both parents, actually. Yeah, 2%. Fathers transmit microRNAs and other things that influence mitochondrial function. And maternal and paternal age influence whether you're at risk for having an autistic child, for instance. So there are lots of variables that play a role. There's zero doubt that parental health, maternal in particular, mainly because Not only is she giving you an egg, but she's also growing you in her womb. And so you're exposed to all of her hormones, you're exposed to any inflammation that she's got going on, you're exposed to all sorts of other things, and you're exposed to her entire diet. And so I guess what I would say is that we know with certainty that we do inherit vulnerabilities from our parents. Some of those vulnerabilities are hardwired into our genes, and some of those vulnerabilities are in fact epigenetic. In my mind, the hope in that is that epigenetic variables are often malleable or reversible. Genetics are not right now. We need gene therapies for that, and we don't really have them for humans for the most part. But epigenetics are malleable and reversible. Usually, the most powerful interventions to change epigenetics are lifestyle factors. And so I would still work with someone using a similar strategy, that if I see somebody who's having severe mental or metabolic health symptoms, so they have biomarkers of metabolic dysfunction, or they, in a normal mental health evaluation, they're telling me I'm hearing voices, or I have chronic unrelenting depression, or whatever, I now think, if there's not an obvious reason, because again, we have to rule out normal and extreme human experiences. So if they're being traumatized, then I need to rule that out and say, well, the treatment for that's obvious. We need to get you out of the traumatic environment. But if I conclude that they have a brain disorder resulting in those symptoms, I'm thinking you have mitochondrial dysfunction somewhere in your brain or body that's contributing to this. And then I'm going to think, what can we do based on today's knowledge to try to improve that? And then I'm going to think about I'm going to look at all of the things that that person's doing that are probably harming their metabolic and or mitochondrial health. And that means they're not getting enough sleep. They're using drugs and alcohol. They're maybe on prescription medicines that are harming their metabolic health. They're on all sorts of things. They're not integrated in society. They don't have relationships. They don't have purpose. It's a lot of the common sense things that we already know. I'm going to look at all those things and I'm going to say, okay, let's clean as much of that up as we can. For some people, that's enough. They get better. We know that in substance use programs. Get them off the alcohol and everything else goes away. Like they become new people, everything. For some. We also know from substance abuse programs, we get them off the alcohol and they're tormented human beings. And they're struggling and they're craving and they're depressed and what can we do for them? So assuming we've cleaned up everything else, we've cleaned up their diet, they're getting sleep, we've done as much as we can, they're off the drugs and alcohol, and they're still struggling. The way I think about that, they still have mitochondrial metabolic dysfunction somewhere in their brain. I'm thinking about Nora Volkov's brain scans. They have glucose hypometabolism in their brain. Their brain cells aren't getting enough energy. What can I do to help give them more energy? Again, Nora Volkov went ketogenic diet. That might be a way to get a different kind of energy to those brain cells. If those brain cells are having trouble using glucose, let's get ketones to those brain cells and see if that makes a difference. And in her research, it does, both in rats and humans. And there are more trials going on. But there are a myriad of supplements and other strategies, light therapy, red light therapy, saunas, cold exposure, all sorts of things that can improve mitochondrial health. And so even when somebody comes out vulnerable, we can't change that. Like, I can't do anything about that. If your mother had a serious mental illness and obesity and had diabetes when she was pregnant with you, I'm sorry. That sucks. Like, that's really unfair. You come out a vulnerable human being through no fault of your own. So that means for that person, it probably is going to be a harder life, and it's going to be more challenging to achieve metabolic and mental health. But I have no reason to believe that it's impossible now. I tend to be an optimist. I see people healing and recovering. Like, I didn't share these stories. Hundreds of people who have suffered from chronic depression, bipolar disorder, schizophrenia, are sharing their stories of complete recovery. Their illnesses are going into remission. Many of them have gotten off of psychotropic medications. They are happy, healthy, functioning human beings. So I know it's possible. If we can get more research, if we can get more clinicians figuring out all of the complex nuances of when should we use this, when should we use that, what should we do for these people, what should we do for those people, I welcome it. Like, it's an overwhelming task treating the world. So we got a lot of work to do. By no means am I trying to say we've got all the answers, because we don't. But with science and knowledge, there's an easy path to getting better answers. So, and I'm really thankful that we're going to be starting this program here at McLean. So, yeah. We're way over time, but if you guys, I'm so passionate about this work, and I don't have anywhere to be. So if you want to stay, I'm happy to stay and entertain.
I'm wondering from like a public health perspective. Like I'm really struck by the health inequity question. So like I'm thinking about someone who doesn't have access to care here at McLean and can't come in and go to your program and can't get all these scans and tests and can't afford whole good foods or all of these treatments. Is there a concern that's just going to widen the gap of health inequity, and kind of how would you answer that? Because it just feels like the sick are going to get sicker, the poorer are going to get worse health outcomes, and the wealthier are going to get healthier. And I'm just wondering if I'm sure you've thought of it and kind of how you answer that.
So
yes, and I raise money. That's why I asked that question.
The real answer is that anytime there's a breakthrough treatment, the rich get it first. So the rich are going to get it first. And I know more billionaires now than I ever in my life thought I would ever know. It's overwhelming and humbling and dumbfounding. I'm also working with some billionaire philanthropists who are quite passionate about making sure that this is not only for the wealthy, that this applies to inner city children here in Boston, that we are going to get them real whole food. We are going to develop interventions for them so that they can thrive and grow and avoid metabolic and mental health problems. The reality is that there are a lot of resources available today. There's a nonprofit organization, there are many nonprofit organizations focused on real whole food. There's a nonprofit organization called Food is Medicine. It has a Massachusetts chapter that if you have a diet prescribed by a healthcare professional, they will get you that diet. So if I prescribe real whole foods, whether it be a Mediterranean diet or a ketogenic diet or whatever, they will offer food. And they do it in the least expensive way. So for some patients, they'll deliver groceries so that they can make all the food themselves. For patients who are unable to do that, they might deliver prepared frozen meals based on whatever real whole foods or ketogenic diet or whatever that they can put in their refrigerator or freezer and make, and just microwave or whatever every week or every day, and they're set. Those resources are going to be limited. Most people aren't using them, though. Most people are completely unaware of them. So I think that if we can develop better strategies, there are a lot of philanthropists who are interested in making a difference for underserved communities. The real answer is it's overwhelming. People are begging me to help underserved kids in inner cities. But what about the Native Americans? They're dying of suicide and alcoholism. Chris, you have to help them. What about people in prison? They're in prison because of their brain problems. You've got to help them. we need to serve them so that they have a chance to get out. Like, they've had horrible lives. They're not getting decent food. They're not getting any of this. Why aren't you doing this for them? I have a lot of people, thousands actually, coming at me. Do this, help these people, help them. Doing what I can.
I was listening to what you said about how ambivalent you are about the current the atypical antipsychotics, which reverse your metabolism in a direction you don't like. So as a clinician, do you feel comfortable prescribing olanzapine or, Risperdal or any of them, which are known to disrupt your metabolism for short-term effect, and they are effective, or they can be effective?
100%. So I still have patients who are on antipsychotics, including olanzapine. For the most part, I get referred patients with treatment-resistant mental disorders now. The standard of care is that we have to use an antipsychotic for somebody's first episode. We can't, this work doesn't change the standard of care overnight. So we have to continue doing the standard of care. The good news for me as a clinician is that the patients that I do work with have already had the standard of care and it's not working. And they're not doing well. And so I have full license to use off-label treatments, which include things like the ketogenic diet and other strategies. And if they respond to the strategies that I'm employing, I try to get them off of those medicines. And the reality is, for a lot of them, they get dramatically better when I do get them off. It's not, they get like 60 or 70% better. I don't change their medicines at all at first. I just see, can you change your diet? Can we get you into ketosis if I'm using that strategy, whatever. When they get 60% better, they're usually thrilled and delighted because they're like, oh my God, I feel so much better. Their families, their jaws are dropping. They're like, oh my God, this is impossible. Like, what is happening? They're hallucinating less. They seem normal for the first time in 20 years. Like, what on earth have you done? But they're still having hallucinations sometimes, or mild delusions or other things. And that's when then I'm going to start to very slowly, cautiously, in a medically supervised way, taper them off those antipsychotics. And the reality is I get them off, they get better and better. It just keeps getting better. And but it's hard. And when people have been on those meds for decades, it's really hard. And it's really unsafe. People should not do this on their own. And unfortunately, because we don't have clinicians and services to offer these treatments, thousands and thousands, tens of thousands of people are doing these treatments on their own now, emboldened by what I'm saying, wanting to get better, but it's not fair to them. I don't think it's fair to them. I think we need more resources and clinicians offering these treatments so that we can do things like that in a safe, controlled way. All right. Thank you all for staying a half an hour later. Thanks.